Hello there. This is Dr. Verlage again with our uh, next presentation in the series to discuss issues and problems in addressing perinatal mental health issues. I am a psychiatrist and I help with the consult line, MTPAL consult line, which is meant for any kind of provider or health worker who needs to discuss a patient who is in the perinatal period, pregnant or postpartum, and needing to speak to a psychiatrist about any issues going on or questions about a patient. So, the presentation for today is addressing disparities in perinatal mental health. This is the third in the series. I encourage you guys to watch the other ones that talk about why it's important and kind of some general numbers from about prevalence and care. This is, I think, a reasonable next step, looking at a little bit closer about access to care, but how that might be different depending on demographics, so that we can try to identify patients who may not be getting the care that they need or at higher risk of not getting the care that they need. So, let's see here. So, in a very, very broad summary of, again, some of the earlier presentations, perinatal, meaning during pregnancy and postpartum depression, is a very significant public health issue and can affect nearly 20% of people in the pregnant or postpartum period. There are lots of negative outcomes that, come from untreated perinatal depression. This lists a couple, but from other presentations we know there's a lot of negative outcomes, health outcomes, mental health outcomes. So impaired infant bonding, higher risk of suicide in mother, especially in the postpartum period. The frustrating thing with our situation is that we have interventions to help, but we're not getting enough people into care. So again, across the board, people are not getting as much access to care as they need, especially for racial and ethnic minorities. So this presentation is going to examine that a little bit closer. So I'm going to go through a number of studies, or two studies specifically, but the summary of those two studies is that non-Hispanic white individuals are significantly more likely to receive treatment for these kinds for perinatal mental health conditions than, say, their Black or Hispanic counterparts. That's very common in many health outcomes, so no surprises that it's here too, and doesn't minimize our need to do something about it. Women who are minorities and who are screened positively for depression, so I'm going to talk about how there's an issue with screening, but even those who are screened for depression are about half as likely to be referred to treatment than, say, their non-Hispanic white counterparts. So that is a big issue. So the first study to paint the picture was the UMass Chan Medical School study, so the study was not initially intended to look at these outcomes, but it was a randomized controlled trial looking at interventions for perinatal depression. Again, wasn't looking specifically at race. However, they did a secondary analysis of the data that did look at maybe these kind of demographic differences. The amount of people who were screened positive for depression were fortunately pretty equal in terms of numbers. So 149 non-Hispanic whites screened positive for depression in the sample, and 157 minority patients screened positive. And then, the population or the patient range was between early pregnancy and even up to about a year postpartum. So that is our kind of sample that they were looking at. And so the key findings were a lot of issues or differences in referral rates. So, and they found that was the most significant barrier to mental health for minorities. The minorities who were referred, at least in this study, were statistically just as likely to initiate and sustain treatment as their non-Hispanic white counterparts. Now, again, this is one study, but at least in this sample, it was truly an issue with referring. Once the patient got referred, they engaged in treatment. So that, looking at all these numbers, that seemed to be a place of a real problem, of getting people care that needed care. And it just highlighted how important the role of healthcare providers, OBs, PCPs, to initiate the process of actually referring patients, and how it could be very impactful if we look at that specific part of this process. So they were trying to figure out, why this difference, and there were some ideas. Community stigma, fear of discrimination or legal consequences by the patient, of, either initiating care with providers or screening differently. Fear of discrimination or legal consequences, low social support, limited time and resources, lack of access to culturally sensitive care, that's a big one, and implicit biases among healthcare providers to say not send a referral or not is also maybe a place that explains this difference. Also, language and cultural barriers, distrust of traditional healthcare and medical institutions. That goes back to a lot of problematic things in our history and are very valid. And exposure to discrimination during clinical encounters. If even seeing any kind of professional in the medical community is very vulnerable. And when you're met in any of these encounters with discrimination, it takes away from all the potential benefits they could get from seeing providers. So, something I hope and believe we're working towards being better at, but I hear stories and there's still a lot of room for improvement. And also, I think in other presentations, I've talked about this new role that you have as a mom and the expectations that other people and yourself have for what that looks like, and the stigma of feeling like it's not looking like that. That whole kind of maze of what's going on mentally is, an important one to consider. And I think normalizing postpartum or pregnancy conditions, talking about them, asking about them in very non-judgmental ways, is so important because of this new role this mother is in, the vulnerability that she's in, the disappointment she's feeling. Our words are very powerful. How we phrase things is very powerful. How we screen for things is very powerful. So thinking about all of these things that might be leading to, people who are already at the vulnerability of being a new mom, but also a minority, it's, can definitely impede them getting the care they need. And everything we can do to keep them comfortable is so important. So there's those barriers. I think the study was also kind of wondering about economic barriers, which obviously play a huge role in access. So women who are employed may not have the logistical time to seek care. They Women with higher household incomes are more likely to seek care, possibly because of their ability to afford it. They have more work flexibility. They have access to support systems to coordinate that. But yeah, trying to explain this discrepancy where household incomes of $50,000 to $74,000 a year were more likely to seek consultations with those incomes than those who were making less than $25,000 a year. So that just initial meeting with somebody in the healthcare community is a factor contributing to people getting access less. All right. There's this other study. Now, this one's from England, but I think, unlike the other one that was designed for, say, different purposes, but then they looked specifically at demographic data, this one was specifically looking at these racial disparities from the beginning when it was created. So it is from England, but I think still could translate and helpful for us to understand the landscape in general. So this one looked at differences in access and utilization of mental health services during the perinatal period. It included 29,000 women, or over 29,000 women, who had one or more recorded contacts with mental health services. And these were a lot of new people to mental health services. So 75% of them were new to mental health services. So women who were minorities, white other is how they categorized Asian, Black African, Chinese, and other, had significantly lower access to community health services than, say, their counterparts, white British women. The number of attended visits was significantly higher among all Asian and Black ethnicities, as well as white other as compared to white British women. So the number of attended visits, I wonder, could be a number of things. So minorities were making more of those visits. I believe, it might be that they showed up more, but also that they were scheduled more often. Maybe could be like a indicator of acuity or of symptoms. But that was something they found in the study. Now, white, other, so all the minorities had statistically higher rates of involuntary admissions than white British women. And involuntary admissions, is kind of an outcome that it's important to have available, but does tell us that an outcome that, treatment didn't go as well as it could have, say. So for implications to policy, women and ethnic groups with lower access to rates in the community mental health services have a higher proportion of involuntary admissions. It's more of access rather than utilization. So again, from those bullet points, minority women went to more visits if they had access to care, but overall had less access to care, leading to this higher hospitalization rate when we look at overall. So access rather than utilization is the policy relevant concern. And it highlights the need to address these systematic barriers that makes it so that minorities have less access to care. So those two studies I talked about were about, looked at referral rates and access rates. This other study looks at screening rates. So those two assume that screening happened. This one looks at, how much is screening occurring for these conditions? And so ACOG, the American College of Obstetrics and Gynecologists, they recommend screening for all patients for depression during and after pregnancy. According to a 2020 study from that was a collaboration between a Minnesota-based mother-baby clinical service line and a mother-baby mental health program, women from ethnic and racial minorities were less likely to be screened for postpartum depression, which again, the precedent, the formal recommendation is everybody gets screened. So this is, anybody who doesn't get screened is a failure of formal recommendations, and whatever system's set up that isn't doing that, it's an issue. And again, minorities were getting screened less, so why? So the lower rates of screening, there were lower rates of screening for minority and non-white people. So connecting screening to treatment. Most women with perinatal depression, including those identified through screening and obstructive practices, so screening did happen, did not get appropriate treatment for their symptoms. And so, sorry, this is just a summary slide of putting together what we've seen. Women who get screened, people who are minorities get less access to care, and minorities are getting screened less. So it's like a twofold, you think of at every step, you lose more and more people to getting the treatment that they need, that we have available. And minorities get hit on both sides. So that leaves a lot of people who are minorities not getting the care that is there and that they need. And we really need to ensure that screening happens, and that screening translates to a tangible support and intervention. That's, this consult line, one of its goals is to do just that. Which I jumped ahead, potential solutions. So having targeted interventions to make sure that there's equitable and consistent referral processes among healthcare providers. It should be standardized. Standardizing the referral process once an individual screens positive, and then trying to address any implicit biases there might be from healthcare providers that could be influencing these numbers too, which you would hope that a standardized process would help mitigate that if it were a component. So a lot of these studies looked at kind of hard numbers of, do they get care? Do they get screened? But understanding the why. There were some bullet points about ideas of why that might be. Stigma, access, to support, being, wondering about what would happen if they screen positive and what that means for their baby and legal consequences, all those things. Those are ideas, but we don't have the specific research for that, which would be a huge help to helping us understand what interventions we can do to help these women get care. So further research is needed to identify these specific barriers, further research to better understand health disparities and to develop programs to address them, especially for minorities, and to identify the roots of access gap for racial and ethnic minorities and better meet the demands for mental health services. So, in conclusion, we continue to see how much work we have to do. I think there's minorities have it more difficult on basically every level. And to think that even at the very beginning of life with these babies facing these discrepancies just shows how kind of large scale and complicated this problem is. And the idea of helping these moms be able to be the mother they want to be and enjoy motherhood how they, hope to without depression is a really kind of meaningful way that we can try to change these systemic issues. Again, just one piece of it, but to think, again, a new life is starting with a mother who's feeling well, I think is a nice way to start. So that wraps up the talk for today. Yeah, you can always reach out to me if you have any questions. Please start using that consult line as much as you can so that we can get all of these women care that they need. And yeah, have a lovely day.